Right. I know people are filtering in, and I got a lot of emails. Oh, is this going to be recorded? Like, of course, we know people have busy schedules. So, for those of you who are joining us live, thank you for carving out the time. And for those of you who are watching the recording, we're so glad that you found time to tune in and listen. I'm really excited about today's session. So, I'm going to do quick intros and then pass it on so that we have maximum opportunity to hear from Dr. Abel and Monica Jones, who is the head of Pediatric Epilepsy Surgery Alliance and mom to a kid who's had several epilepsy surgeries. I'm Gabi Conacher. I am mom of a 12-year-old Elliot who lives with SCN8A DEE and the co-founder of Deep Connections, which is really all about bringing together the rare epilepsy community to better understand key issues and ask questions and provide resources and empowerment to families. So that's what we do here. And we're really excited for today's discussion. If you have other topics that you want to hear about, please reach out, let us know, and we'll be following up with a survey at the end where we ask you to share what you thought and what else you want to know about. But for today, if you're joining as a participant, no worries, you are not on video and you are automatically muted. So don't worry if you're doing laundry or you have a kid who's crying in the background. We get it, and you're safe here. You don't need to worry about that. Today's webinar, excuse me, will be recorded. So you will be able to come back and listen and check it out again. And when we post it, we will share a lot of resources, or basically tell you to go over to the Pediatric Epilepsy Surgery Alliance website, which is chock full of amazing information and resources and support. And please use them. That's what they're there for. And they do an amazing job. So I'm going to go ahead and hand it over to Monica Jones, who is going to introduce Dr. Abel, and then we'll get started. If you have questions throughout, please drop them in the Q&A. Use the chat to talk about what's resonating with you, what you're thinking, what you're feeling. If you're surprised, we have a pretty good chat going there throughout, so feel free to use that to connect. All right, over to you, Monica.
Thank you, Gabi. Wonderful to collaborate with you and Deep on this really important webinar. I'm Monica Jones. I'm the founder and executive director of the Pediatric Epilepsy Surgery Alliance. And I'm really excited to introduce to you all today Dr. Taylor Abel, who is currently on our board of directors, and he was previously on our scientific advisory board and is as well as that, the chief of pediatric neurosurgery at the UPMC Children's Hospital of Pittsburgh. Today, he's going to talk about what the research says around whether or not pediatric epilepsy surgery extends the life of children with drug-resistant epilepsy. We've all heard those very scary statistics about our kids having a higher rate of death caused by SUDEP, et cetera. And I just want to remind you all, and if you haven't heard this before, that if your child has a drug-resistant epilepsy, they're supposed to be referred for a surgical evaluation, regardless of age and regardless of the type of, for example, cause of the epilepsy. So if they have a genetic epilepsy, they have something that traditionally hasn't been referred for epilepsy surgery, they're supposed to be referred for a surgical evaluation. It's your right as a parent to understand all your child's treatment options. If your child has a surgical evaluation, it doesn't mean that you have decided your child will have surgery. It means you've decided to have all cards on the table so you know the next best step for your child. So Dr. Abel, thank you for joining us. I'll let you take it from here.
Thanks for the invitation. And I just want to say that I really appreciate the opportunity to talk with this group. And I'm really inspired by all the work that the Pediatric Epilepsy Surgery Alliance does. And I'm less familiar with DEE-P, but I'm also really inspired just by the work you're doing also. I'm an epilepsy surgeon. I work at the University of Pittsburgh. I've spent my whole life being interested in epilepsy because I actually had benign Rolandic epilepsy of childhood. So I had a type of epilepsy when I was a kid, and I think being in neurology clinic as a child and seeing other kids with epilepsy got me really interested in being a neurologist, actually. And then in school, I just got more interested in surgery. And that kind of led me to do what I'm doing now, which is I'm a pediatric epilepsy surgeon at the University of Pittsburgh and Children's Hospital of Pittsburgh. So the title of my talk is, Does Epilepsy Surgery Extend Life? And we'll kind of start really broad and talk about why epilepsy surgery. We'll talk about, but ultimately I'm going to conclude that I think it does. And there will be some caveats to that, but we'll get into that. I'm going to try to keep it simple. I'm going to try to not talk for very long, and then hopefully we have a lot of time for questions and discussion. I think in talking about surgery, it's always really important to start with a patient, to start with an example of what we're talking about. And today what we're talking about is death in epilepsy, mortality in epilepsy. And this is a patient that I took care of who, for over a decade, or about a decade, she was having really severe seizures. And she had an evaluation that revealed this brain tumor in her left frontal lobe that you can see here. Let me see if I can actually draw on here. So there's a brain tumor. And the brain tumor wasn't growing, but it was causing severe epilepsy. And her caregivers were really nervous about having any kind of intervention or surgery for this because being a cheerleader was really important to this girl. And she was one of the cheerleaders that she's like a flyer, something like that. But she does the stuff where she's like high up. And so there was be a lot of risk of having a craniotomy. But unfortunately, when she was on vacation with her family, she had an event where she had a seizure in a pool and she drowned, or she had a near drowning event, and she was admitted to a local hospital for several weeks. She came very close to dying, because she had had a seizure in a pool. But she's another otherwise very high functioning young lady. And so several years after this drowning event, I finally got to meet her, and we went over some other options for her care. And so what we talked about there's this option of having a traditional type of epilepsy surgery where we would remove this tumor through a craniotomy, or we could do something called laser ablation, where she could actually go back to being a cheerleader right away. And we talked about maybe it's not quite as effective as doing a traditional type of epilepsy surgery, but it would kind of respect her values of being a cheerleader, and also hopefully take care of this problem. And so that's what we did. We actually did a laser ablation procedure. You can see that we placed this small probe into the tumor, and then we performed, this is what the ablation looks like immediately on the MRI, but then we performed an ablation of the tumor, and she's been seizure-free since this laser ablation procedure, where she only had to spend 1 day in the hospital. And she now doesn't have seizures. She was previously having 8 seizures a day that were really interfering with her life. And so this is it's now been quite some time from surgery. So this is an example of how epilepsy surgery is really important to consider. It's really important to spend a lot of time with families and making sure they understand the pros and cons of each options, and building trust so that families feel safe discussing things that can be really scary, because having epilepsy surgery in this case, for example, is a lot safer than not having it, because now her risk of having a seizure when she's in the pool or a seizure when she's doing like cheerleading is really, really low. She most likely will be seizure free for the rest of her life, because this is tumor-related epilepsy, which responds really well to epilepsy surgery. And this is an important anecdote that illustrates how risk of death can be a lot lower after epilepsy surgery. Why do we talk about epilepsy surgery? There's something called, I know a lot of people that are listening to this are familiar with the idea of drug-resistant epilepsy, or have heard the term drug-resistant epilepsy, but it's important to talk about what drug-resistant epilepsy is. And it has a clear definition, which is an individual with epilepsy is been trialed on 2 appropriate anti-seizure medicines, but are still having seizures. Even if it's just 1 seizure a month or a couple seizures a year, that is still drug-resistant epilepsy. And the reason that definition is important is because if you have drug-resistant epilepsy, your odds of becoming seizure-free on an additional medicine is 5 to 8%. So your odds of becoming seizure-free is really, really low once you have drug-resistant epilepsy. And so having drug-resistant epilepsy should prompt a referral to a center that does epilepsy surgery. And so these are the timing to referral to evaluate for epilepsy surgery expert consensus from the International League Against Epilepsy. And what this says is that if you have drug-resistant epilepsy, you should be referred to a center that offers epilepsy surgery and has experience with it. And what this guideline also says is that actually, if you don't have drug-resistant epilepsy, you're just on one medicine, but you have a lesion in your brain, like a cortical dysplasia, or a brain tumor, or a tangle of blood vessels causing your seizures, you should be referred for epilepsy surgery before you become drug-resistant. And so that's an important distinction, is that epilepsy surgery should, in these special cases, be considered before you are even drug-resistant. Evidence for epilepsy surgery, there's a lot of it. We're going to go over the most important ones. This paper from Sam Weeb is one of the most important ones because it showed that having epilepsy surgery for temporal lobe epilepsy compared to not having epilepsy surgery, the medical group here, is associated with higher rates of seizure freedom. And you might say, well, 38% is a lot lower than what my surgeon told me in clinic. And the reason for that is because their inclusion criteria for being included in this study was having a temporal lobe resection and only having 1 centimeter of the hippocampus removed. But oftentimes we're removing 2 to 3 centimeters of the hippocampus when we do a temporal lobectomy. And that's probably why in other studies you see the rate of seizure freedom for temporal lobe resections about 50% for or higher for MR negative, meaning there's no lesion. But when there's a brain tumor or mesial temporal sclerosis, the seizure freedom rate after temporal lobe epilepsy surgery is like 70 to 80%. So it's much higher than what you're seeing there. A lot of people on this call are thinking specifically about children with epilepsy. And this is a really important landmark paper that was published from an epilepsy surgery group in India, that what they did was actually they randomized children to having epilepsy surgery or not. And the way they were able to do that, without getting into some equipoise issues or ethics issues of having delayed care, is that this is a center that, because of their large population base, had a wait list for epilepsy surgery. And so they could randomize where children were going to be on this on the list, because they had a list. And what they showed is that children that have epilepsy surgery, this group here, they're doing way better than the medical only group in terms of their seizure control. But also what's important is it wasn't just seizure control, which you see here, but it was also seizure severity, and it was also child behavior, and it was also quality of life. Those things all did better in the surgery group compared to the medical management group. And so that's why we really think carefully about referring early to epilepsy surgery. I want to show another case at this point before I go kind of do a deeper dive on epilepsy mortality, just to show an example of why early referral is so important. This is I'm going to show a 2-year-old that presented with spells of behavioral arrest and unusual eye movements. he was started on Keppra, and imaging and EEG was obtained. And this is what the imaging showed. And so you can see here that there's a very, very large tangled blood vessels. This is a cavernoma. And obviously this should not be there. This should not be there, okay? And I think even if you're not a radiologist and you're just a parent watching this, looking at this, you can look at this and say, this should not be there. And this child actually had a cavernoma syndrome where because of their genetic makeup, they actually have multiple of these cavernomas throughout the brain. And so they were diagnosed with multifocal epilepsy. They were started on a medicine. They were referred to a neurologist. The Keppra didn't work, so they tried another medicine. They had the genetics evaluation. They had another MRI. 2 months after his first evaluation, he's now having 5 to 10 seizures a day. He still hadn't seen an epilepsy specialist. He does get 2 months of seizure freedom, but he's now on 2 medicines. Later on, he starts having 5 seizures a day again. At 1.5 years, he finally sees an epileptologist. He started on a 3rd medicine. His seizures get to a point where he's getting hospitalized. He's still not been referred to a neurosurgeon or had an epilepsy surgery evaluation. I don't describe it here, but he's beginning to have language problems. Like his language is not developing the way you'd expect it to. Probably he's starting to appear like he has rather than a focal epilepsy, more of like a generalized type picture. And so maybe he's starting to develop some features of Lennox-Gastaut type epilepsy, though that ended up not completely happening. And so here's what's really sad is that my daughter was having a play date, and somebody was picking up my daughter. The kid's mom was picking up my daughter's friend and said, and she said, "What do you do for a living?" And I said, "Well, I'm an epilepsy surgeon, whatever." She says, "Oh my gosh, you wouldn't believe it. My nephew, we just don't know what to do. He's having seizures all the time, and we just don't know what to do about it." And so I said, "Well, yeah," and I imagine there maybe it was something where there really wasn't anything to do. But I said, "Why don't you just have me take a look? Why don't you have the mom call me? Here's my cell phone, and I can look at the images and things and just make sure everything's squared away." So I was on the family that night. I saw him in clinic 2 days later. We did surgery a week later, and he's been seizure-free for now several years. This should never happen. You can see me getting a little emotional, and it's because we should have done surgery earlier, and it would have been life-changing for this child. And we will never know how it would have affected his development. But these things are common enough that they happen in our community. And if it wasn't for my daughter having this friend that was on a play date, I would have never learned about this child. And so this is another illustration of why I think early intervention can be really important. It can change a child's development. And what I'll now show in the rest of my talk is that it may have even changed this child's risk of death. So now let's go over that stuff specifically. So the main focus of my talk, and I'll probably only talk for another 10 minutes because it's already 12:20 and I want to leave a lot of time for questions, is does epilepsy surgery reduce mortality? And what I am going to argue is that any intervention that reduces seizure frequency is probably associated with reduced mortality in individuals with epilepsy. I'm going to show that there's a lot of evidence for this. And there's some evidence that doesn't support it perfectly for things like VNS, but I will argue that even in these situations where it might not be perfect, there probably aren't downsides with regard to thinking about reductions in mortality. So now let's get into it. This is a paper from Cassidy et al. That investigated all-cause mortality and SUDEP. SUDEP stands for sudden unexpected death in epilepsy in a surgical population. And so I'm an epilepsy surgeon. I'm not necessarily a SUDEP expert, but sudden unexpected death in epilepsy, my understanding is that because it's happening in young patients, it results in a similar number of years of life lost from a disease as, I think, stroke. So, or some other things that are really common. And so SUDEP is something that we want to do everything we can to reduce the risk of SUDEP and other types of mortality in epilepsy. And SUDEP is not the only cause of mortality in epilepsy because, like I showed you with the first case I showed at the beginning of the talk, there can also be really tragic things like drowning in a pool or things like that during a seizure that can be really tragic, and result in mortality. But look at this data. I think this data speaks for itself. This is the group that had epilepsy surgery, and this is the group that didn't. And you can see the number of SUDEP cases, which is here, is way higher in the group that did not have surgery compared to the group that did. And so I think this kind of speaks for itself and is kind of a powerful example of how epilepsy surgery can reduce mortality. This is a systematic review and meta-analysis from some people that are really, really experts in this field. Sylvain Rimes, Michael Sperling, and Philippe Rivlin. Philippe Rivlin really being a SUDEP expert. And they did a systematic review and meta-analysis showing that surgery leads to a twofold decrease in the risk of death and a threefold decrease in the risk of SUDEP. They also looked at neuromodulation studies, meaning like VNS, and they conclude that neuromodulation is a little bit less clear. But I'm going to show some data in a few slides that talks about that. This is a really cool study from Sandy Lamb's group, where they did a comparison of long-term survival, comparing continued medical management, vagus nerve stimulation, and cranial epilepsy surgery in children with drug-resistant epilepsy. So this is a very large observational cohort study. The downsides, the upside of these big data studies is that you have like tons and tons and tons of individuals that get enrolled in these studies. The downside is that you don't have as good of control over like the data or confounding variables, things like that, that are often important to controlling a study, but these are still really important lines of evidence. And what this shows is that this is a survival curve. And so you want the line to be as high as possible because that means people are living longer. And so you see the blue line, which is the surgery cohort. That line is like all the way at the top the entire time. It goes all the way out to like 15 years. And so that's like as good as it gets. That is great. You can see that the VNS cohort, that line is not quite as high as the cranial surgery line, but is also quite high. It's higher than the medical management line, which is this line right here, which you can see is lower than both cranial surgery and VNS. And so what this large observational cohort study shows is that whether you're having cranial epilepsy surgery or VNS, it's associated with increased survival. And so this is a really important study that was published in Lancet Child and Adolescent Medicine. So one of the things that my research group does is we use mathematical models to simulate different clinical scenarios in situations where where it could be really expensive or really difficult to do clinical trials. And so what we did was we developed, actually I can say because I actually did this myself. I developed a mathematical model that compared open surgery to laser ablation to having just medical therapy for children with focal drug-resistant epilepsy. And then in this model, I considered whether they had a complication or no complication, whether they became seizure-free or not seizure-free, and then whether or not they had to have redo surgery or no redo surgery. But then after all those things happened, they then enter into what's called a Markov chain model, where that simulates every year of their life for the rest of their life. It makes assumptions about standard mortality rates, whether you're seizure-free or not seizure-free. And so I created that model and simulated thousands of patients going through this model. And what the model shows is that actually, this assumes that you have epilepsy surgery at age 10. And so on average, if you have epilepsy surgery at age 10, it adds about 5 years to your life, based on this mathematical model that incorporates data from a lot of different studies that have been published and synthesizes that data into this mathematical model. And so that's really important because considering epilepsy surgery can be really scary. And so it's really important to be able to tell families that even though going through this is really scary, this can add 5 years to your life on average. Because, and I tell you what, 5 years, a lot can happen in 5 years. Think of all the things that can happen in 5 years and what value that has. And so this is unpublished data that I'm preparing to publish as soon as I have time to finish writing it. So, but I think the data is pretty robust and compelling. There's also some data again from Philippe Rivlin and some other folks that he works with that looked at really large cohorts of patients treated with VNS or not, and compared their SUDEP rates. And actually showing that after implantation, the risk of SUDEP goes lower with vagus nerve stimulation. And so this gets back to this question of, do neuromodulation therapies, meaning you're not having resective epilepsy surgery, you're just having a VNS placed, does it reduce mortality? And this study would suggest, yes, it does. I want to be balanced in my presentation. So this is a study that looked at a smaller cohort of patients, but it was really well controlled. And this study concluded that standardized mortality ratios and SUDEP rates were comparable to other cohorts with intractable epilepsy. VNS did not appear to reduce the risk of premature death overall. And so I want to be balanced and show that there is some debate in the field about whether or not VNS does reduce mortality rates. Some papers show that it does. Other papers like this one show that it doesn't. And so there's some debate about this. So we're actually 30 minutes in, and this is usually where I like to conclude, so we have a lot of time for questions. My conclusions are that epilepsy surgery is really important in epilepsy management. It can improve seizure outcomes, quality of life, and also cognition. I didn't talk a lot about cognition today because it wasn't really the scope of this talk, but there are a lot of evidence that shows that epilepsy surgery can even improve development, prevent developmental decline. We didn't talk about that much, but it's really important. Interventions associated with decreased seizures are associated with decreased mortality. I think that's pretty clear. It seems that resective epilepsy surgeries are associated with decreased mortality, and that seems really clear. There is evidence that neuromodulation such as VNS is also associated with decreased mortality, but this is less clear, and there's more debate about this. But what I would say is that if you're hedging your bets, why not? It might give you some more of a reason to consider these therapies, that there are several studies that show that they're associated with decreased mortality over time. So with that, there's plenty of time for questions, and maybe we can open it up, or whatever the next step is.
Yes, thank you so much. I think we covered a lot of ground. That was really incredible. I learned a lot. And I'm wondering if we should have another evaluation, is what I'm thinking. I don't know if you have thoughts on that. I mean, you get evaluated once when a kid is 2, your kid is 10, 12, 15. Is it good to do later again because things have changed?
I think it really can be. I think things change over time, and I think having follow-up evaluations can be really important. Just because things change and technologies change, and that can be really important.
Yeah. We have a lot of questions that are coming in and a lot of gratitude already for all of this really incredible information. We have one question about that their child is having absence seizures daily, but that they aren't damaging to her, but the mom feels like they might be. And they were evaluated a few years ago for surgery, and that she wasn't a candidate because her seizures fire in all areas of the brain. And we're not asking about this specific person, but in a case like this, where seizures are firing from everywhere, is that still someone who's a case for surgical intervention?
This is a great question. And so let's say that this sounds like maybe it's generalized epilepsy,
Mm.
but generalized epilepsy is something that where there used to not be as many surgical options, but now there really are. In fact, there's great evidence showing that neuromodulation can be for very effective for both primary generalized epilepsies, when generalized epilepsy is occurring secondary to a genetic abnormality, or also secondary generalized epilepsies like Lennox-Gastaut type syndromes. So for Lennox-Gastaut specifically in young adults, we have what's called the ESTIL trial. That was a trial that the Australians did that shows efficacy of central median deep brain stimulation. And then in the United States right now, we have the Nautilus trial, which is a trial of central median responsive deep brain stimulation, I believe, or excuse me, responsive neurostimulation in adults, but also young adults down to in teenagers down to I think age 14. But we've had really good results, at least in our observational cohort at Children's Hospital of Pittsburgh, with children with primary generalized epilepsy using central median RNS. And I guess I should take a step back and say what these words all mean. So RNS stands for responsive neurostimulation. And this is when we put an electrode in the brain that senses when you're having seizures and then stimulates your brain in response to the seizures to treat the seizures. And we found that to be effective in up to 80% of individuals who have that procedure done. Deep brain stimulation just means we're putting electrodes into the brain that are stimulating all the time rather than responding to seizures. But that's also been effective for these generalized types of epilepsies. So I think the answer is, I think you should have an evaluation at a center that that does surgery for generalized epilepsies.
Yeah, that's a really important point. And Monica got at this in the chat too when she shared that. I don't know, Monica, if you want to talk for a second about that, because I think Dr. Abel did a great job of pointing out what those different neurostimulants are. But
Yeah, I shared a great video that actually Dr. Abel did with his friend and colleague, George Ibrahim, who's at Sick Kids Toronto. It's spectacular. It explains the difference between VNS, RNS, and DBS. what the different devices are, where they go. And then there's a follow-up presentation from our conference this summer or last summer, where they kind of updated us on what the research says. So sometimes I think clinicians, doctors think of epilepsy surgery as just the surgeries where part of the brain is cut out or maybe lasered off. But it's really this whole category of surgeries, everywhere from VNS, which is neuromodulation, all the way to removing half the brain, which is what my son and Audrey's son had, which sounds draconian in many ways. Audrey's son is in college. If you want to watch a video about or a documentary about my son's life and her son's life, it's called Life with Half a Brain. It's on Amazon and Tubi, to kind of take away the shock of, my gosh, you took out half your kid's brain. Well, but we do have a result that is very favorable. Anyways, there are just so many different surgeries out there that you can consider. It's not just these surgeries that cut out, but you won't even know that your child is a candidate if you don't have a complete surgical evaluation. And it has to be at a facility that has experience. So you have to ask really, really hard questions that sometimes may feel off-putting to the team, or you may not have the confidence to ask, but I say, do it. Ask them how many they've done, what the research is around it. Ask the hard questions, because that's how you get the information.
And this is a great transition to this other question, which is, who is qualified to actually tell you whether your kid qualifies for surgery? I think a lot of people have said in the chat that their neurologist told them, oh, you're not a good candidate, or, who is the person that should be telling you? So it's a surgeon, right? A surgeon is one who should evaluate, not just a neurologist or an epileptologist. Is that right?
I think the best person is a surgical epileptologist. So it's an epilepsy doctor that specializes in epilepsy surgery. So at our center, we have two of them, Well Welch and Rubal Ramadani, and they are epileptologists, but they specialize in epilepsy surgery. And so we have several other epilepsy doctors, but they will refer their patients or discuss their patients with these two. And then they'll spend a lot of time with the families, and then they'll engage me, or the families will talk to me before, but then I'll go back and talk to them later.
Yeah, so that's a
So
good
it's
phrase,
a team
right?
approach.
Yeah. But if for families who's like maybe general neurologist or epileptologist say you're not a good candidate because maybe we can talk a little bit about generalized, focal, all these different terms that come up. And some people say, well, the seizures are coming from so many different parts of the brain, or it's generalized epilepsy, and therefore you're not a candidate.
I think if anyone, I think it's tricky because I think having access to child neurology in the United States can be really difficult, especially in certain parts of the country.
Yeah.
I trained at the University of Iowa, where in Iowa, getting access to a child epileptologist was really, really difficult. A lot of epilepsy was treated by pediatricians
Hmm.
that maybe weren't even necessarily neurologists. So I think one benefit we have these days is that you can get a second opinion from a center outside your region via teleconference pretty easily. And you want to make sure you go to a level 4 epilepsy center at the very least.
Yeah. But that phrase that people can say, if your doctor, your pediatrician saying, or your neurologist saying you're not a good candidate, you can say, I would love to have a referral to an epilepsy surgeon to discuss my options, right? So
Yeah,
people
I
can feel
think that's
empowered to say
important.
that if they're being told no, no, no.
Yeah, I think that's important. Because if you're not a candidate because you have generalized epilepsy, there's almost no situation in which there's not a strategy that might be at least worth discussing.
Hmm.
Can I just comment real quick? You have to determine what your goals are. So with generalized epilepsy, especially, you might not be able to get to 0 seizures. So you have to really manage your expectations around what the devices may give you in the end, at the end of the day. May not stop the seizures completely, but it may substantially reduce the seizure burden. The second thing, if your evaluation was years ago, imaging has changed, protocols can change. Focal cortical dysplasia is a jerk and does a really nice job of hiding on MRI. So you want to go back in to an experienced team to take another look, because you might not have seen cortical dysplasia when your child was 1 or 2, but now that they're 10, it shows up much easier perhaps, or the imaging is better, or the neuroradiologist at the hospital is much more experienced than the radiologist that was reading the MRI 10 years ago at your local hospital.
Yeah, definitely. And there was a question about genetic. Someone mentioned, a lot of these disorders where people are candidates for some kind of surgical intervention, and it's not necessarily about whether it's genetic or not. It's about whether it's drug-resistant epilepsy. And does genetics matter in this at all in terms of, what the etiology is, what the actual diagnosis is?
Um, I think different centers would debate this, but I think one thing that's key is that just because you have a genetic diagnosis, that does not take epilepsy surgery off the table. I think there may be some important considerations around what the genetic diagnosis is and what treatment you consider. But I don't think there's a situation where you shouldn't consider epilepsy surgery because you have a certain genetic diagnosis. It should still be something that's discussed with the complete team.
And does brain atrophy play a role in if someone is eligible for brain surgery at all? Someone was asking about that.
Not necessarily. It shouldn't be something that stops one from considering epilepsy surgery. In fact, sometimes it can help you localize the area of the brain where seizures are coming from. We also now recognize that actually having uncontrolled epilepsy over a period of time, Marian Galovic has a paper that shows that it actually causes brain atrophy. There are other more extreme examples like Rasmussen encephalitis, where it causes quite profound brain atrophy over a pretty rapid time scale.
Mhm.
And so that should not be something that prevents consideration of epilepsy surgery.
Wonderful. And, we have some questions about, if there's a lesion and it's in like risky areas of the brain, I think, are there some surgeons that may feel more comfortable going after something like that as opposed to others, or is that considered like too dangerous to go after if it's in a challenging part of the brain?
Great question. I think I actually just while I was listening in, I responded to Lindsay's question.
Uh-huh.
But I think the important thing is that you're at a center that's really comfortable mapping these different areas. And so, because sometimes you have to implant electrodes into the brain so you can identify where motor cortex is or language cortex, these areas that are really important to preserve function, so that you can either plan your surgery around those things very carefully, or potentially, if you identify that the seizure area overlaps exactly with motor cortex or language function, that you put a brain stimulator into that area, like something called RNS.
Yeah, and someone was asking if they already have a neurostimulator like a DBS or a VNS, does that disqualify them from having brain surgery as well?
No.
Yeah.
There might
Um,
be some other considerations, like getting certain MRIs and things can be maybe a little bit, there's some considerations there, but it should not prevent it.
mhm, yeah. And there's a question about RNS versus DBS, and I think that link that you put in the chat, Monica, before probably has a lot of that other video with Dr. Abel. And are there benefits to going with one over the other, or what makes the decision about whether you go for RNS or DBS? You mentioned how they're different, but are there
Yeah.
different considerations for who's more likely to get or might have more success with an RNS versus a DBS?
I think there are a lot of considerations, and I try to think about trade-offs. So like I think with patients who have LGS, there's just a little bit more evidence right now for deep brain stimulation of the centromedian nucleus. So that's one consideration, is there's just a little bit more evidence there. Um, I think the other nice thing about DBS is that the DBS companies have rechargeable batteries that can last like 15 years
Mhm.
if a family is charging them regularly. And that can be really great because a lot of our children who have DBS, they're dealing with a chronic condition, and having to come in every 3 or 4 years for a battery change if you have a battery that's not rechargeable is really like difficult. Um, so those are some important considerations with DBS. With RNS, I think something that's really beneficial is that the batteries probably last like 10 to 11 years, something like that.
Mm.
But what's really beneficial is that the RNS generator itself records seizures. And so every time you change a medicine or something like that, you get a readout of how many seizures someone's having from direct brain recordings. And that can be, I think that
Mm.
also has a lot of value. So I don't think there's necessarily like a hard and fast one is better than the other. I think it's like a tailored thing that requires like some shared decision making between physicians and families when making these decisions.
Yeah, yeah, absolutely. Monica, you want to jump in with anything that's coming to mind for you as you're hearing all of this?
Uh, it's a tough comment to make, but so I made the decision to have half of my son's brain removed, and so did Audrey, which results in pretty substantial deficits, if you can imagine, partial blindness, a very substantial weakness opposite the side of the surgery. I know that some parents are concerned about deficits associated with certain surgeries, but I do encourage you, parent to parent, to step back and really think about what a lifetime of uncontrolled epilepsy will do to a child, not just in this context of survival, but behavioral arrest, stopping progress, regression. Some of us have made the decision to, in exchange for seizure freedom, to have our child be partially blind or only able to use one hand. That's not a decision anyone else can make for your family, but you and your loved ones and anyone who's in your decision-making circle. Mom to mom, I guess, parent to parent, I would just say, always step back and think about the long road as well when you're making these decisions. Not easy, trust me, we know these are terribly difficult decisions to make. There are a lot of resources that we have for you, where we can connect you with a parent, for example, who's walked the journey before you so that you can just talk it out with them as well.
Mm, yeah, really fantastic resources. What about in terms of, somebody who's had several surgeries and maybe things aren't happening with each one? Do you continue to refer for different kinds of surgeries, or, what is considered? I guess partially it's exactly what you're talking about, Monica. Success is what you hope to get from it, and it's, seizure freedom may not be on the table for a lot of our kids, but how do you measure success, in a surgery? And then do you continue to do surgeries if there are options on the table that, if seizures keep changing or the location?
Um, I think it's really important to look carefully at what's been done and why it's been done. Make sure that there was a correct diagnosis,
Mm,
because sometimes maybe so sometimes it can be helpful to get a second opinion or just a second look at things to kind of look back at how things have been done and why they were done. But then the other thing is that with all the new technologies that are out now, there are these trade-offs between things that are like a little bit less invasive but not as effective, and things that are tried and true and really effective but maybe a little bit more invasive. And and so I think this has made epilepsy surgery a little bit more. I think we're seeing more patients that have had several of these less effective interventions before getting, and maybe a lot of them actually end up not needing a larger intervention,
mm,
but then some of them do end up needing a more traditional intervention to reach their goal. Um, and so we do see some of this, and it's just important to have everything looked at very carefully and before proceeding with the next step.
yeah. And maybe we can talk a little bit about the journey as well. I mean, Monica, you guys have an incredible network of families who are there to support families as they consider surgery and then also after surgery, right? So it's not just about that making that very difficult decision to begin with, but then the road after. Do you want to maybe talk a little bit about how you support families after that decision is made?
Yes, we can connect you with a parent with a similar surgery before the actual surgery itself. We recognize these are really traumatizing events that happened in your family. My son's a triple surgery family, so I never thought I would say that out loud. I thought the first surgery was the worst, and actually the third surgery for us was really terrifying. But all of us have lived experience, can walk you through this. After surgery, I think that's really our sweet spot. We can help you navigate IEPs. I don't know anyone who loves an IEP, but we are really good at helping you navigate reentry into the school system. Lots of therapies, research that we've done around that. Helping you understand the impairments that come from some of these surgeries. I'm speaking at the American Academy of Audiology the last week of this month, actually around a paper that Taylor published, or Dr. Abel, excuse me. I think
You
I
call
can
me Taylor.
Taylor now. Around auditory impairments that can come when you resect the temporal lobe or have a TPO or hemispherectomy, a bigger procedure, making the school aware of that and how that might affect a child's ability to sound out words or to cross the street because they can't hear a car coming. So, and then Audrey Vernick, who's on this call, really has just a command of transitioning to adulthood. And Gabi, I know we've already done a webinar with you around all of the things that are associated with having a child with complex medical needs or intellectual impairment or whatever it is, and when you're starting to think about adulthood.
Yeah, no, that's brilliant. And Dr. Abel, that's very generous of you to drop your email in the chat there, I see. So if you have questions that don't get answered here, Dr. Abel's put his email in the chat for folks. So yeah, I think, we've covered a lot of ground today talking about, I think case studies were really fantastic to hear those. I think that's a great way to model some of this decision making and potential outcomes and outputs. Um, are there are there stories that from the other side of the coin? I mean, obviously there's some, surgeries that aren't successful. They maybe don't hit the spot. They, it's doesn't change everything dramatically. What other things should families be aware of? And hopefully their neurosurgeon, their epilepsy surgeon is doing this processing with them in advance about, what could happen, what might happen, what might not happen. But, are there other things that should be taken into consideration when, before going into surgery and building your expectations? And Monica, you might speak to this a little bit too about, what's realistic.
I mean, this requires honest conversations with the surgeon. It requires honest conversations with yourself. You know what I mean? Does that make sense?
Mm-hmm.
I think that, we're a triple surgery family. My son, it was really a difficult disconnect, and now there's cortical dysplasia in his healthy hemisphere. So none of this is straightforward. I don't know if that
Yeah.
answers the question.
Right. There's no guarantees.
There are no, but you're at 0 chance of seizure control. All of us on this call, we're at 0 when we're looking down more medication. You know what I mean? So managing your expectations and exploring these options is really critical.
Mm-hmm.
0% versus 40%, 0% versus 60, 0% versus 85.
Right.
It's not 0. We're at 0 when you're looking at adding more meds and what the meds do.
Yeah. So many of us are on 3, 4, 5, 6 medications. And we know, I mean, from my son too, it's just, we don't know who our children are underneath that, right? It's like, I really wonder what he would be like if he would be more awake and more available to learn and engage. So I think that balance of more medications, and with all of our drug resistant epilepsy kids, so many doctors focus on let's add more meds, let's add more meds. And it's hard to get off of meds then, right? But, is there some statistics about, kids being able to come off of or reduce medications after surgical intervention? Obviously not everybody, but how often are meds still used as part of a treatment protocol after surgery?
I think with things like with neuromodulation, I don't think there's great evidence for reducing medicines after neuromodulation therapy. I think the most I've looked at is VNS, for example. With resective epilepsy surgery, I think the first step is becoming seizure free. And if in our center, what we do is if you're seizure free for 6 months, we get an EEG. And if the EEG looks okay, then we'll start tapering off one medicine at a time. And we just see how it goes. And then if a seizure comes back, we just restart the meds, because then we just, our goal then is to be seizure free on meds.
Mm-hmm. Yeah, and hopefully less meds.
Yeah.
Right. Yeah. All right. I'm just looking here to see if there's any other things that come up here. You know, anything we haven't covered yet, Monica or Dr. Abel, that you think is important to put on the table for families? I think we've covered a lot of ground. And, our hope here is really to empower you all to feel ready to go in and ask your doctor to help you on this journey and give you access to more options. And if you have not spoken with an epilepsy surgeon, to really help review your case, look at the MRIs, evaluate what's going on, that's really your right. And if you get pushback from somebody, find somebody else. Don't take no. You all are incredible advocates. Every single parent who is managing children living with all of these complexities, our jobs, become, being chief advocate for our child. And it's about asking the difficult questions and pushing back if we're getting people telling us that, that we're not a good candidate, or, that doesn't apply here. And I think, we wish more doctors were like Dr. Abel, who are, allowing families to help be in the driver's seat when it comes to, getting all the options on the table and making those decisions. But, we want to really empower you to ask for the things that you deserve, so that you have all the options on the table for your child. And maybe surgery won't be the option right now, but, I think whenever people, you run into a hard spot again and you're running out of medications, maybe in 5 years, maybe that's another time to have that discussion again. Maybe things have changed. Maybe more surgical options have arisen. Maybe your child's MRI looks different. So, don't think of surgery as a last result. It's an option on the table, and you should consider it at times when you're considering a new medication. Maybe this is the right time to consider surgery again. So, I just really want to thank both of you, Monica and Dr. Abel and Audrey, who's been in the background sharing things. And we'll make sure all of these links get shared. This is so valuable to do, and to really have these conversations on a regular basis. So we're so grateful for the work that both of you do, and for sharing that with all of us today.
Thank you, Gabi.
Of course.
Thank you for the invitation, and I'm inspired by everything that you and Monica do.
Thanks. Yeah. Well, we're lucky to have great partners. That's what makes it work, is when there are clinicians who are really excited to share this information widely, and also be advocates for our kids, from your end. So thank you so much, and take care, everybody.
Thank you.